Hi everyone, welcome to tonight's Mini Med School. I'm Emma Eggleston, Dean of the WVU School of Medicine, Eastern Campus. So February is National Heart Health Month, and it's a good time to remind ourselves how to take care of one of our most precious organs. Tonight we're really fortunate to have two of our Heart and Vascular Institute cardiologists, Drs. David Plitt and Umut Goncelli, and they are going to lead us through recent advances in cardiac care with a particular focus on women's health. Thank you, Drs. Goncelli and Plitt. We look forward to learning from your talk.
Well, hello everybody. I want to thank you for joining us on the Mini Medical School talks here. I'm honored to be here to be one of the presenters. And my name is Dr. David Plitt. I'm an interventional cardiologist with WVU Division of Cardiology. I work here in the East Division at Berkeley Medical Center, among other locations. And I'm privileged here to talk to you today about advances in cardiac catheterization. So before I begin here, something we all have in common here is that heart disease is our #1 enemy. Heart disease remains the leading cause of death in the United States and worldwide. Now this, of course, is a conglomerate of diseases. This includes coronary artery disease or heart attacks, congestive heart failure, arrhythmias, and structural heart disease, which includes heart valve disease as well as congenital heart disease, which people are born with and often presents earlier in life. Among these, coronary artery disease, for adults at least, remains the #1 cause of cardiac death. And this is displayed here in this graph here from the CDC that depicts the leading causes of death in the United States in adults. And as you can see, for the years 2016 and 2017, heart disease was certainly the top of the hill in terms of the leading cause of death in the United States. This has remained constant both before this time and since this time. Even last year during the COVID pandemic, heart disease remained the leading cause of death for the entire year. Now, coronary artery disease, or plaque buildup in the arteries, is the major cause of myocardial infarctions or heart attacks, which is the major cause of cardiac death in adults. To show you briefly what that means in graphic representation, you can see here a heart artery, or any artery for that matter. On the top, there is a nice looking artery with free-flowing blood through it. In the middle, you can see that there's some plaque buildup, all of that yellow sort of gunk here in the middle here, plaque buildup, which restricts blood flow through that artery. And in some cases, that leads to a blood clot forming, which restricts blood flow completely from going through that artery. And that is what ultimately can cause a heart attack. Now, the good news is that there are many known risk factors for cardiac disease, for coronary disease. Some of these, of course, are out of our control. However, many of these are under our control. And together, knowing these, we can help prevent, not completely, but to some degree, the development of cardiac disease. An ounce of prevention is worth a pound of cure, and that's very true in the world of cardiology. So let's talk a little bit about prevention here before we get to the main portion of my talk. So there are things I said we cannot control. We cannot control our genes, for instance. We cannot control our gender. Heart disease is more common in males. We can certainly not control our age, which is the leading or biggest cause of heart disease in adults, is advancing age. However, there are many things we can control. We can control whether we eat predominantly like this or whether we eat predominantly like this. We can control whether or not our behavior looks more like this couch potato or whether or not we exercise regularly. We certainly can control whether or not we smoke, and to a large degree we can control our weight and our waistlines. All of these things can help prevent the development of heart disease if done thoroughly and in a consistent manner. We hope at the end of the day that the scale, our scale, tips in balance of no heart disease as opposed to heart disease. But as we all know, this is very hard. It's hard to do this consistently and perfectly. Why is this so hard? Well, time, right? Many of these things take time. Exercise takes time. Cooking our own food takes time. Money. Joining a gym, an exercise program often requires money. Eating healthy food and not succumbing to the temptation to eat fast food every day, that takes more money. Boredom. Last year during the COVID pandemic, many people who are out of work, that deprives them of their get up and go attitude, the ability to go drive to work, walk, up and down stairs at work, do all the things that are part of our daily life that are sometimes we're deprived of. And technology. Technology is a great thing. It certainly allows me to give this presentation to you all today. However, it also makes our life a little bit lazier in some ways. If you need to look something up, instead of getting on your bike and going to the library like people did 100 years ago, we just ask Alexa or we get on our computer. In many ways, this is opposed to what President Roosevelt advocated for 100 years ago or so, what he called the strenuous life, a life of toil and labor and effort and strife. And in many ways, the strenuous life is what can help prevent the development of heart disease. But is that really all there is, you may be asking? Well, what about when these traditional measures just aren't enough? And in many cases, unfortunately, they aren't. Well, this is one of my favorite doctor comics here. And the two doctors are standing outside the patient's room and they say gleefully, "We called him just in time. In another day or two, he would have been cured by himself." Well, that may be true comically in some cases of medicine. However, for vascular disease and cardiac disease, it unfortunately is not often the case that you can be cured by yourself when disease has started to develop. That's why we have advances in cardiac care. We have medications that are more effective, that have fewer side effects. We have newer blood thinners. We have blood pressure medicines. We have everybody's favorite, right? Statins, right? We have newer cholesterol medications that are not statins. All these things have been shown to help prevent heart disease when lifestyle changes just aren't enough. We have procedures. We have cardiac catheterizations, less invasive. We can do them on sicker and sicker patients as time goes on. And finally, we have improvements in processes of care. This includes more efficient and streamlined methods of delivering care, improved patient satisfaction, and cost savings for the healthcare system, all benefits of improved processes of care. And this is what I'm going to focus on mainly for the remainder of my talk. So this is a common scenario, right? Your doctor may say that you have to have a heart catheterization and maybe a stent. And many questions come to mind. What does this mean? Are they going to have to push on my groin for hours like they did 10 years ago or like they did for my dad 20 years ago? How long will I have to be in the hospital? And will this cure my problem? All common questions that having to have a heart cath may prompt. So let's talk a little bit about the patient's cath lab experience. I think that's an important part here. So this is a cath lab, a generic photo. There's a doctor here performing the cath on the patient who's sedated and draped under these sterile drapes, looking up on the screen here to see exactly what the pictures are showing. Now, to have a heart cath done, the doctor has to gain access to an artery, typically the groin artery. However, nowadays we can do it through the wrist artery. They have to advance catheters, long tubes basically that are shaped differently for different purposes, up the artery to the heart and inject X-ray dye and obtain pictures. And you hope that your picture looks like this. This is a nice normal looking heart cath. Arteries that taper as they go out, just like branches of a tree, with no noticeable blockages. However, what happens when this develops? What happens when we find this very tight blockage or narrowing here in this one big artery? Well, that's what percutaneous coronary intervention is for. This is a fancy way of saying putting stents into heart artery blockages. It's interesting to know about the history of these things so we can understand how we've advanced to where we are today. This is Dr. Andreas Grunzig. He's the inventor of this field, who in 1977, using rather primitive, somewhat homemade technology, was able to treat the first patient with a balloon angioplasty. Here's a theater of scientists and doctors from around the world who were in the audience watching eagerly. And this was his patient. His patient had about a 90% blockage here in this artery. And after his angioplasty, and 10 years later, it looked like this. That's pretty good. And he came to America, and he established a practice at Emory University in Atlanta and brought this technology to America and the world. I had the privilege of training there for a year, and here I am outside the Andreas Grunzig Cardiovascular Center, which of course is named after him. So we've come a long way, baby, since then. And this obviously is a very simplified timeline, but if we start in 1977 and move forward, we've had advances and improvements in catheter design. We've had advances with the development of stents, and even better stents as time has gone on. We've had advances in medications, better medicines during the procedure to limit bleeding risk and after the procedure to help protect the stent. And we've also had advances in how we do the procedure in terms of how we gain access to the body in less invasive ways. Let's talk about that last one for a second, because it's that last development that's really allowed us to make strides in improving our process of care for patients in the cath lab. All arteries lead to the heart. Now, typically this procedure was done through a small incision in the groin artery, and that worked very well. It's usually done through a small puncture site, like putting an IV in. However, when you're done, that equipment has to come out, and that leaves a hole in the artery, which of course will bleed and can bleed significantly. That's why we have to put pressure on the groin, and this is a primitive way of doing that that is still used today in some cases, called a femstop, a device that puts external pressure on the groin site to keep it from bleeding. And I don't know, some people think it looks more like a medieval torture device. But we have newer and better ways of doing that now. We have ways to put stitches or even little plugs of glue into the arteries, which allow patients to get up quicker and potentially go home sooner. But even better than this, we have developed alternatives to using the groin for this procedure. We now routinely can use the wrist artery. It does the same purpose. It's a little bit harder technically for us, but it's better for the patient. They don't have to lie flat afterwards. They can get up and walk around much quicker. It's done similarly through a small puncture in the artery in the wrist, just like putting an IV in. But when you're done, instead of that sort of big, bulky pressure device, you get a nice, nifty little bracelet here, which keeps pressure on that site. This is much better than that medieval torture device that I showed in the previous slide. So we've had advances in this aspect of care. So how does this affect our overall process of care for the patient and what you may be seeing or may see soon here at Berkeley Medical Center? So percutaneous coronary intervention, placing stents in heart arteries, has traditionally been followed by an overnight stay in the hospital to monitor for complications. Most importantly, bleeding from the site used, as well as stent-related complications, such as blood clots that can form on a stent after it is placed. These complications have been substantially reduced in the recent years by use of more advanced equipment, better medications that limit bleeding and help protect the stent better from clotting, and alternative vascular access locations using the wrist instead of the groin. This has led us to revisit the necessity of an overnight hospital admission following uncomplicated stent placement, or PCI. Isolated hospitals describe the safety and feasibility of same-day discharge after a PCI in the mid-1990s, with the first major trial published in 1999. Potential benefits of this approach, of course, include healthcare cost savings, improved patient satisfaction. Despite this, however, the practice of same-day discharge after PCI has been slowly adopted in many parts of the world, including the United States. Right? The old adage, old habits die hard, is very true in medicine as well as other aspects of life. So how do we find that balance? So this is one extreme. You have the patient who comes in with the suitcase anticipating and expecting an overnight stay. We have to contrast that with the patient who's discharged a little bit too early, what I call the hospital gown sign here, walking through the streets still in their hospital gown. So let's talk about same-day discharge after PCI here at Berkeley Medical Center. Individual physicians have adopted same-day discharge on an informal basis, but this has been sparsely utilized. This year, the cardiology department here hopes to implement a same-day discharge formalized process here at Berkeley Medical Center. This effort will involve many people: physicians, nurses, techs, secretarial staff, administration, clinic follow-ups, outpatient clinics for follow-up appointments, etc. So this is very complicated, I know, but I wanted to show it in brief. This is a protocol that I've developed in the past and implemented elsewhere for this exact scenario. And the point here I want to make is that it's a very thorough algorithm. And the idea here is to maximize safety, making sure that we're not sacrificing safety, while also allowing us to select those patients who might be able to go home that same day after they have an uncomplicated stent procedure. And there are many aspects to this. There are things that we can identify before the procedure, that we know about the patient's demographics even before they come into the hospital. There are things that happen during the procedure, the type of procedure it is, how risky it is, if there's any complications from the procedure. And there are, most importantly, things we can identify after the procedure, things in recovery, mainly looking for any bleeding complications, any signs by vital signs that maybe things aren't quite in order for the patient to go home that same day, and to make sure they have appropriate follow-up and that they live relatively close should a problem develop that night. When all's said and done, there are many places where patients could fall out of this algorithm, and that's how we maximize safety, while at the end hoping that many patients will be able to indeed go home that same day and follow up soon as an outpatient. This process will not apply to all patients. It is based upon many aspects of the case: the patient comorbidities, the degree of complexity of the procedure, the patient's recovery, the time of day, geographic factors, how far the patient lives from the hospital, etc. Thus, although same-day discharge after a PCI will be an option for many patients, it should not be assumed to be the case and should be thought of as a bonus. So we're not quite here yet. We're not quite at the drive-by cath lab scenario depicted in this comic, but we have made tremendous strides over the past 40 years, 50 years in this field, and we're trying to bring those newer developments here to Berkeley Medical Center. So I thank you for your attention. Oh, one more slide. I want to get back to that question I asked near the beginning about, will this cure my problem? And I want to remind everybody that a stent is not and should not be thought of as a cure. It certainly helps in many cases, helps people with symptoms, helps people in some cases prevent heart attacks, but it's not the cure for this problem. It should be thought of as a really big, important Band-Aid. However, just as important, and maybe even more important going forward, is all that healthy lifestyle choices that I mentioned earlier in my talk. So I want to thank you. This is me here in my Carbonite Han Solo costume with my family, and I want to thank you all for your attention and hope you enjoy the Mini Med School series.
So I am Dr. Gömceli from Berkeley Medical Center, Heart and Vascular Institute, and I would like to take this opportunity to talk about the women's heart disease and its importance since this is the Heart Month, February 2021, this year basically, since being like this 2003. I would like to emphasize the importance of the heart disease in women. Personally I believe this is the missing part and the weakest part of the medicine that we are practicing right now as a cardiologist. So we know that the cardiovascular disease is the most dangerous and killer disease all around the world, and US is not exempted from the situation. But why cardiovascular disease is more important in the women? Because they are more prone to develop worse consequences related to heart disease, basically. What is cardiovascular disease? What should we understand when we say cardiovascular disease? Cardiovascular disease is a heart and blood disease. Usually, these cannot be separated from each other, basically. They are the part of the same system, and it develops in the circulatory system, basically, and we have different consequences related to their location that are happening. What are we understanding when we say the heart disease? These are coronary artery disease, briefly heart attack related to blockage in the vessels of the heart. That could be a cerebrovascular disease, which includes the brain into the circulation problem and presents as a stroke or transient ischemic attack, which is like a milder form of the stroke. Also, high blood pressure, congestive heart failure, congenital cardiovascular defects, and the peripheral vascular disease. These are all the extension of the same disease group, basically. So again, women are not exempted from the current situation, and the cardiovascular disease is the #1 health threat to the women as well. So they are more vulnerable by more vulnerable to the cardiovascular disease when compared to men. I will try to explain why. Heart disease is the #1 killer. Basically, I'm talking about the heart attack when I say the heart disease here, and the stroke is another cardiovascular disease extension, and that's the #3 killer. So we all thought that, like, it's since the the modern practice of the cardiology for decades, basically, we thought that, and also the patients thought that the cancer is a bigger threat to the women's health all around the world, basically, but actually that's a myth. So that's not true. The cardiovascular disease is a way more big threat to the women's health all around the world, basically, and kills more women than the cancer, COPD or chronic lower respiratory disease, and the diabetes combined. So I would like to show this diagram here to be able to show how much cancer kills and how much cardiovascular disease kills. So actually the red diagram, red pie I'm highlighting here is the cardiovascular disease, which is responsible from the 41% of the all deaths all around the world, basically. And the cancer is only 22%. And the rest of the pie is pretty much negligible when you compare with the rest of the disease group. And again, the cardiovascular disease prevalence amongst the minorities are higher than the majorities, basically, especially the African American woman has like a 48% higher chance of getting cardiovascular disease than the Caucasian woman. It's like 33% when you compare to the 48%. And the women age 45 and older are likely less likely than the men of that age group, 74% versus the 81%, to survive a year after their first heart attack, which means women are more likely to die after their first attack. All around the world, with many interventions right now, so we are taking some advantage on cardiovascular disease with the medical treatment, with the other treatment modalities, and these decrees are more pronounced in male race, basically, male gender, basically. And the women, unfortunately, they have a still increasing number of the cardiovascular disease. Whatever we are doing, we are unable to show that that's working better for women right now. This has like many explanations, basically. First of all, the cardiovascular disease is a preventable disease. A recent study, nearly 75% of the cardiovascular disease cases in women can be prevented with better life choices, such as not smoking, exercising, or eating healthy diet. So we will go over this in the next couple of slides. And again, the importance of this month is creating some awareness about the situation. So this initiative started by the NIH in 2002 as a first Go Red for the women and the Wear Red for the awareness in the Heart Month since 2002. American Heart Association found that the 44% of the women are unaware of their heart disease. That's another important point to create an awareness of the situation, basically. So the 44% of the women are not believing that the leading cause of death among the women is the cardiovascular disease. Again, we have some minimal increase when you compare to the 1997, which was only 30% at that time. So again, they are less aware of about the situation because they are not expecting it. So they don't believe that the cardiovascular disease is the major cause of the death among them. So unfortunately, this causes the underestimation of the symptoms and overlook of the symptoms by either patients themselves or the provider themselves. Uh, Only 65% of the women said the first thing they would do if they thought they were having a heart attack was to call 911. Only 65%. Unfortunately, this lack of awareness extends to the women's health care providers, as I explained, so resulting in less aggressive and sophisticated diagnosis and treatment with worse outcomes. And the heart attack symptoms may be different than the woman, may be different in the woman than the man. They tend to be more atypical when you compare with the man presentation in terms of heart attacks. And we are always talking about the patients regarding the risk factors here and there. Many times we come across with this risk factors, what those are. So for the cardiovascular disease, aging is a major risk factor for the women. About this is having a menopause or not having a menopause. Basically, the menopause is the starting point where their chance of having heart disease like drastically change and becomes like a more steep by the time just after having the first menopause, because we believe that the hormones are the protective until the menopause happens, the ones, especially the estrogen. So once the menopause happens, estrogen levels drastically drops, and basically women lose their protection against the cardiovascular disease. And the risk for the cardiovascular disease increases 2 to 3 times after menopause. So again, minorities are most vulnerable part of our community, and African American women has a higher risk of death from the heart disease than the white women, as we explained before. And let's continue with the risk factor. We say age, we say race, and also cholesterol levels. There are like a lot of misconception about the cholesterol. Cholesterol levels are very important in the predicting of the heart disease. Basically, that could be just sporadic, could be like individual, or they can run in the family. Basically, women at age 20 and older with the blood cholesterol levels like pretty much 200 or higher. These are white females, like 54% of them has this kind of like a high cholesterol levels. Black females like 46%. Mexican Americans have like 45%. These are the study results showed. So basically cholesterol, when we say the cholesterol, what it means, this is the fat in the circulation. And we have like different types of fat and different processing styles of the fat in the body. We have a good cholesterol, which is HDL. We believe that it's a protector against the cardiovascular disease. We have bad cholesterol, which is the LDL cholesterol. We don't want it to get higher than normal a lot because it's quite associated with the heart attack or stroke in the future, basically. There are different ways to increase the good cholesterol, and there are different ways to decrease the LDL, which is the bad cholesterol. Basically, we will go over that. Another risk factor is the high blood pressure. So it's always called a silent killer because it goes unnoticed for a while, and meanwhile it creates the damage. This is true for men and women actually, but women after age 20 and older, like white females, has almost 30% higher blood pressure, and black African American females has like 45%, and the Mexican American females has 30% high blood pressure. Pretty much every couple of years, we are having different guidelines, and the cutoff for the high blood pressure changes by the years based on the studies. So usually the latest I would call like roughly systolic blood pressure, which is the highest number when we measure our blood pressure, systolic 130, and the diastolic, which is the lowest number when we measure our blood pressure, over 80, usually accepted as a stage 1 hypertension and high blood pressure, and this is usually the cutoff for the treatment of the high blood pressure at any age and risk group. Diabetes is another risk factor. Pretty much we consider it's a noun entity, but again, it's always overlooked or underestimated. Basically, increasing the heart disease like 3 to 7-fold in the community. Basically, a more powerful risk factor for heart disease in women than in men. Basically, that's another importance of the diabetes in women. So, what's diabetes? It's a briefly, body cannot use the sugar, cannot utilize the sugar basically properly, and that sugar hangs around in the circulation and goes and damages the end organs like your eyes, your heart, your kidneys, your brain. So why is that bad? Pretty much 66 to 75% of the people with diabetes die of some sort of cardiovascular disease. Briefly, you can call it like a whole package, comes together. Once you have diabetes, probably you have high cholesterol. Once you have diabetes, probably you have high blood pressure. And at the end, it's going to create a total destruction of your circulation system. Basically, either you will have a heart attack, or you will have a stroke, or you will have a kidney failure. Both are related to circulation related damage of the body as a consequence of the diabetes. And also smoking. So nothing much to say. We know all this is like a harmful, but we are still doing it. So it's very hard to overcome, especially in the clinical setting. So one of the most resistant part of the treatment or the prevention of the cardiovascular disease is the smoking. Single most preventable cause of the death in the United States, which is related to cardiovascular disease. 21% of the American women age 18 or older smoke, and total of 22.6 million women smoke in the United States. This is a huge number, and it creates a catastrophic consequence in terms of cardiovascular disease. So to highlight its importance, basically, if you do not smoke, do not start. If you smoke, just try to quit. Avoid others, tobacco smoke basically. There are ways to stop smoking. Now we have more weapons to use against the smoking. As long as you are willing to quit, there is a help for this, either with like medication, either with encouragement. There are ways to quit smoking, so just the only need is the willing. And the physical inactivity, it's like pretty much we all know that in the modern human, in the industrial age, basically we are physically inactive. Whenever we say like we are active, actually it's not enough all the time. But again, we can do something to be able to decrease the risk of the heart attack and the stroke risk. You don't need to be a marathon runner. You don't need to be an athlete, but you can do at least 30 minutes or more activity on most or all days of the week. At least 5 days in a week, we are you can do like a 30 minutes exercise to be able to control your blood cholesterol, diabetes, obesity, and to be able to lower your blood pressure. Obesity, it's another pandemic actually. Since we are in a strange time, actually we are just forgetting another pandemic. It's obesity. It's all over the world, and more pronounced in the United States basically. Overweight and obese women age 20 and older, white females like 57%. Again, the minorities are more in danger basically. Black females like 77%, and Mexican females like 72%. So these are the numbers, like should make some awareness about this situation, because obesity is there and it is associated with the other risk factors. Once you're obese, you are more tend to have hypertension, more tend to have diabetes, high cholesterol. Oh, sorry. So we were talking about the coronary artery disease, and what we meant when we are saying the coronary artery disease. Basically, the coronary arteries are the small vessels which carries the blood to the heart muscle. So those are the most vulnerable muscles to the atherosclerosis, which is the plaque formation, like mostly consists of a fat inside it, which is cholesterol in this case, basically. And by the time we don't know the like initial insult most of the time, but that could be a smoking, that could be like familial hypercholesterol or stress or something else. It starts accumulating inside the vessels, in your heart vessels, and it creates a plaque formation inside your coronary arteries. And also another extension of the disease is, as we speak, it is stroke, which is completely the same family of the disease group, but the end organ damage is going to be your brain instead of your heart, basically. Again, there's a plaque formation, there's an accumulation of the fat over there, and at the end there's a small blood clot can travel to your brain vessels, and it can stop the circulation to your brain, and it's going to end up with a stroke. Again, these are the sections of your heart vessels. Your obstruction means the blockage of the vessel, basically. That could be in this one location, or that could be widespread in your vessels, basically. Both of them are related to decreased circulation and increased heart attack. So why women don't take action against the heart disease? So it's like a big debate, like for decades. So maybe they don't put their health as a top priority. They think they are not old enough to be at risk. So that's another myth, for example. So right now in the modern ages, looks like the younger women are having heart disease in numbers comparable to the men, actually. They feel too busy to make changes in their lives, which comes with the overlooking of the cardiovascular disease. They are already feeling stressed. They don't have the familial or social support, and these differences may be partially due to hormones, as we speak, the estrogens, a woman's smaller heart size and advanced age at the time of the diagnosis. Women's experience of the heart disease is different than the man's, basically. There is a clear gender differences between the two gender to be able to describe their problems, basically. Women are more likely to die within the 1 year of heart attack. Again, it's like a multifactorial. We don't know why, but there's a clear discrepancy. Women are less likely to survive coronary bypass surgery. It's a surgery we are doing to be able to restore the circulation of the heart, basically, and they are also in a high risk following the surgery. Women are more likely to experience complications after the angioplasty, which is the mechanical opening of the vessel blockage, which is the coronary artery disease, as we mentioned before. Women are more likely to have life-threatening arrhythmias, which is the rhythm problem of your heart, irregular heartbeats, or life-threatening rhythms of your heart following the heart attack, basically. These are all the complications of the coronary artery disease women are more likely to have than men. What are the traditional heart attack findings, and what should make a woman alert about the heart attack and make them take the proper actions about that? So the traditional heart attack warnings are pressure, burning, squeezing in the center of the chest. That could be a discomfort in both arms, shoulders, neck, jaw, stomach, or back. Shortness of breath, fatigue, cold sweat, nausea, or weakness. These are the traditional warnings of the signs, but unfortunately most of the women with a heart attack is not going to present with this. So what can they have? That could be an upper back, jaw, or neck pain, shortness of breath again, flu-like symptoms, nausea or vomiting, cold sweats, fatigue or weakness, feelings of anxiety, loss of appetite, and discomfort is way more common in women than in men. Very non-specific findings and more easily overlooked. So this situation has like two sides. One side is the patient who is unable to describe or atypically describe it's the situation, and the other side the provider doesn't take it as like real event or may overlook based on the atypical findings basically. So sex difference, we already talked about that. So far, the data used for the care of the woman derived from the studies conducted in the middle-aged man. So actually, we are adapting the results from men to the women. So it may not be real. So initial efforts for prevention focused more on men than women. Again, as we said, we always consider that the coronary artery disease or heart disease is a man's disease. So that's why initial efforts to decrease the mortality is focused on men. So unfortunately, we couldn't break that circle yet. And women and doctors often attribute chest pain in women to non-cardiac causes because of the atypical presentation of most of the women with the heart disease. And women tend to have heart attacks later in life than men, which comes with the older age and which comes with the more complication related to age, basically. And women present more often than with atypical symptoms. As we said, some diagnostic tests and procedures may not be as accurate in women. Again, the most of the study findings related to these tests coming from the man. So their specificity for the women is still questionable, and it's a kind of like a limbo in the diagnosis. And the heart disease may be different in women than in men. We have different types. It's a very specific types of the heart disease in the woman, basically, in terms of coronary artery disease as well. But it's the different topic of the discussion. So what we can do, so what tests we have, and what we can do in the Berkeley Medical Center to be able to reveal the coronary artery disease in this patient group. First of all, the key word is screening. Keyword is awareness of the coronary artery disease, which anyone can get. So right now, the most of the guidelines recommending an early screening for all age, every age human being, basically, including women, starting from the 20 years of age, testing for a cholesterol level. Checking first time for the blood pressure, at least in one clinical setting, one office visit. And also, if there is a further suspicion or any further question regarding the either family history or any risk factors, basically, we can proceed with the electrocardiogram, which shows heart rate and rhythm along with the many other invaluable information, basically. So we can do that. Stress testing is very, very common diagnostic modality, which we are doing in many ways. In here, basically, that could be a treadmill stress testing, that could be a treadmill plus echocardiography, or that could be a treadmill plus nuclear scanning of your heart, basically. These are the modalities we are able to do in the Berkeley Medical Center and Heart and Vascular Institute. Also, echocardiogram, which is one of the cornerstones of the diagnosis for heart disease, which is the ultrasound of the heart, no radiation, very simple, no procedures, very quick and very invaluable diagnostic tool. And again, the nuclear imaging is another way to understand if your circulation in the heart is good or bad. And a final step of the diagnosis, that could be a cardiac catheter. You may need a cardiac catheterization, which is the angiogram, which is an invasive observation of your vessels through a vessel, which we can reach either your wrist or your groin, basically, and go and see your how your vessels are doing, basically, if necessary. Usually it follows all this non-invasive testing at the beginning. But again, all the information regarding the coronary artery disease testing comes from the man-based studies, not the women-based studies. So the representation in the studies are quite limited. Basically, for example, ECGs, if we are looking at the study and the ECG results we are looking at, 91% so far is men and only 9% is women. Echocardiography, 79% to 21%, and MPI, which is myocardial perfusion imaging, 72 to 28. It's still biased. So there are different options to be able to treat the coronary artery disease in women after the certain screening and after calculation of the certain risk factors, if you have, and the possibility of having a coronary artery disease in the future. Basically, we can justify if you are a candidate to use any preventive medications, just aspirin or statins, which is used for a high cholesterol or used for the patient group that are at risk for the coronary artery disease in the future, or one step further, balloon angioplasty, which is the mechanical opening of the blocked vessel, or standing along with that. If needed, a surgery, or pacemakers for the slow heart rate, or defibrillators for rapid heart rates. These are the examples of the treatment that we can provide to the women with the heart disease. So again, to wrap up what we said so far, women should know their risk factors, first of all, to begin with. Stop smoking. Maintain a healthy body weight. Eat nutritious, balanced diet, low in saturated fats, which goes by a Mediterranean diet. Monitor and manage blood pressure and diabetes. Exercise regularly. Limit alcohol intake. Moderate is fine. Binge drinking is bad. Learn stress management skills and maintain social relationships. Social relations are good for health, briefly. Now, the warning signs of the heart attack and stroke. So, women can save lives. So, if you or someone you know has risk factors for heart disease, adopt a heart healthy lifestyle and discuss a plan of care with your physician. If you experience symptoms of heart attack or stroke, call 911 immediately, and knowing CPR can save lives. So again, I would like to emphasize cardiovascular disease is the #1 killer of the women in America and all around the world. Actually, the majority of the American women are unknowledgeable of their personal risk for the cardiovascular disease. And changing a woman's cardiovascular risk from higher to lower, which present medical knowledge and tools, reduces her chance of coronary events in the future. And women are often decision makers for the family. So if we educate the women, we will educate the family and all their members, basically. Thank you.